Hi, everybody. Dave Duncan. I'm the director of the State EMS Authority, and I am honored to have the opportunity to speak here today about the state of the state, California Stroke System of Care at our virtual conference. So thank you. I have no disclosures to share. I would like to dive right in and talk a little about stroke treatment, and some regulations. I've had the opportunity to watch, stroke treatment develop over the last 25 or 30 years since my career began, and it's been a very unique treatment perspective to watch. So I want to share a little of that. Stroke is characterized by disrupted blood flow to the brain, and as we all know, death of brain cells begins within minutes, making treatment just imminently time sensitive. Stroke is the leading cause of disability and the fifth leading cause of death behind heart disease, cancer, and others. About 15 years ago, it was the third leading cause of death. So it's good we're moving further down that list. If we can continue to move down further, all the better for our stroke patients. There are two primary types of stroke. There's ischemic stroke, which represents about 85% of all strokes, and it occurs from a blockage, either from a thrombotic event or an embolic event. And there's hemorrhagic stroke, which occurs typically secondary to the rupture of an artery, representing about 15% of all strokes. Early recognition and treatment is key. Treatment is incredibly time sensitive in our stroke patients. There are benefits clear up to kind of a couple of demarcations, 4.5 hours, and then some interventions clear out to 24 hours, but hence stroke systems and treatment centers, an absolute requirement. That's why we're all here. Stroke treatment is a really interesting animal, for lack of a better word. It was a very difficult gestation and really offered a stuttering approach to treatment of this medical ailment. For nearly a century, there were really no interventions. There was supportive care and observation, and people didn't get too excited about stroke for the longest time. Then beginning in about 1995, shortly after I completed my residency, NINDS 1 and 2 kicked off and demonstrated large benefits for TPA in stroke patients. So in 95, we had our first real treatment. We all jumped on that bandwagon, gave a lot of TPA up until really around 2000, 99, 2000, when we had a couple of equivocal studies come out, and people sort of stood back and said, well, wait a minute, were we, in the early adopter class, and maybe we shouldn't have been. So again, TPA and stroke treatment followed a turbulent course for 8 to 10 years. And also mechanical thrombectomy entered the ranks kind of in this time frame with some initial good data and then some stuttering data. And then finally, over the last more than 10 years, we've developed and obtained multiple studies and meta-analyses that have demonstrated clear benefit for both TPA and mechanical thrombectomy. So I feel, we're obviously finally in a great place for stroke treatment and stroke patients, but quite an interesting back and forth stuttering development for stroke treatment. Another aspect of stroke treatment related to the timely alignment of intervention really talks to the communication and coordination required. We cannot align sequential notifications and communication paths. We have to take a parallel approach for both the pre-hospital timeline and the post-arrival to hospital timeline. When we get that pre-notification from EMS, so many pieces have to fall into place. ED preparation, clerical alignment, stroke team notifications, a diagnostic team notification so we can clear the path to the CT scanner. And then the same once we arrive in the ED. these are areas we can clearly improve. Parallel communication is not our forte. We communicate typically through phone calls, pagers, and lots of sort of sequential communication platforms, but we really need to optimize parallel communication and preparation paths. And maybe more to come on this, but this is an area we can sort of target for the future, I think. Our stroke system was developed because of all these pieces required. Stroke treatment is a bit of an art form and requires lots of education, preparation for our stroke centers, and hence specialty stroke systems were created to expedite high quality care. Specialty care facilities, rapid transfer, early treatment, all reduce morbidity, disability, and mortality. And the EMS system, both the EMSAs and EMSA, end up kind of being the gatekeeper for this specialty care system. Stroke regulations, maybe a bit of a stuttering start there. Drafting of the regulations began in 2011, and that was initiated based on Section 2.5 of Health and Safety Code that allows specialty care systems and hospital designations to be regulated by the EMS authority. A regulatory language was initiated and based on recommendations from lots and lots of experts, including Get With The Guidelines, American Stroke Association, American Academy of Neurology, CDPH, Task Force Input, and other subject matter experts. The task force was created by EMSA with representatives from many of the stakeholder groups and subject matter expertise just discussed, so I won't reiterate that, but including California Hospital Association, Emergency Nurses Association, American Stroke Association, Kaiser jumped in, and other subject matter experts. EMSA finally submitted the stroke regulations final draft to the Office of Administrative Law, and after completing the rulemaking process and considering public comment and recommendations, the stroke regulations were born July 1, 2019 as Chapter 7.2 in Title 22, Division 9. Big day for stroke systems and stroke patients. Here's a map of California EMS agencies, just for context. We have 7 multi-county EMS agencies, and we have 23 single county EMS agencies. And many of these in scattered fashion have now adopted stroke systems, and I'll comment on those here in a second. The stroke critical care system regulations note that any LEMSA may develop and implement a stroke system of care. The LEMSA shall have the stroke plan integrated into their EMS plan and approved by the EMS authority prior to implementation. We currently have 21 LEMSAs with stroke plans approved by the EMSA. The LEMSAs submit an annual update of their stroke system plans as part of their annual EMS plans. COVID-19 certainly put a delay in this process, as it did so many other processes in EMS. Here's a quick roster of those LEMSAs with stroke plans. I won't stay on this slide too long. We don't want anybody to get any bad press, but we have about 21 of 33 LEMSAs with stroke plans currently approved. Moving into stroke specialty care center conversation, LEMSAs are authorized to designate the stroke critical care facilities based on the level of care provided. And we have 4 levels of care. We have acute stroke ready hospitals, primary stroke centers, thrombectomy capable stroke centers, and comprehensive stroke care centers. The stroke centers are designated by the LEMSA based on criteria required within the stroke regulations, and also requirements as determined by the LEMSA medical director. We currently have 170 stroke centers designated by LEMSAs in California. We have a stroke technical advisory committee. The EMS established this committee for the state stroke program. The TAC includes nominated professionals that represent MDAC, EMSAC, many of the same stakeholder groups that I mentioned previously, subject matter experts, hospital stroke directors, and LEMSA specialty care coordinators. The TAC meets 3 to 4 times a year, targeting all the items that you would imagine, including data system requirements and improvement, implementation of the regulations, system quality improvement, and other important topics. Stroke system future goals. Again, maybe a degree of obviousness here, but we want to improve participation across the state and within the LEMSAs. We want to get to 33 of 33 LEMSAs. We want to improve the function of our stroke systems. We want to improve the education within the stroke system, but also within the public space. We want to improve data capture and analytics, looking at outcomes and moving towards more timely access to data, both with respect to the analytics and the data capture. Ideally, real-time data would be the ultimate goal. And finally, with all that, we obviously hope to improve stroke outcomes even better in California. So with that, thank you so much for participating in the virtual stroke conference. And I'll hand it back to folks for closure of this session and the conference. Thanks again.
Well, hello, Dr. Duncan. We're waiting. We're waiting for Fareed, Dr. Nasser to join, as well as Tom's going to join us as well for our EMSA Q&A session. Let me just make it, oh, perfect. All right.
Just to note that Tom is going to be join us just by audio. He doesn't have a camera access now.
Okay. Perfect. Well, first I want to thank EMSA. Thank you, Dr. Duncan, Dr. Nasser, Tom, everyone for putting this on. I think it's been very valuable. We've already heard in the Q&A from participants that it's been valuable to them. And so I hope this last session will be their chance to ask you all the questions they need to know to improve stroke systems of care in their system. So I'll just dive into some of the questions that we've received so far. The first one is a big one, but I know you can handle it, Dr. Duncan. So there's, this is really a lot that we've heard today in terms of advancing stroke care and getting more complicated in terms of stroke identification and triage. And it's a lot for providers to assimilate and manage in the field. So do you believe that there are the educational, clinical, and operational capacity and resources to integrate these developments? And what changes do you think need to be made in EMS education and EMS governance to support the enhancement of patient care in the field?
Yeah, that's an easy one. I think that question is so large for so many reasons that extends clearly beyond stroke. But the real question here is every aspect of treatment, all time sensitive, time critical emergencies, everything we do in EMS is growing. Everything we do in medicine is growing. Where are we going to find the time to educate our pre-hospital providers with all of these things? We know every time we all of us try and change a regulation or a requirement for an additional 30 minutes, much less an additional hour of education, that we get tons of pushback, which is appropriate. It's additional time, it's additional money. But the answer I'm going to give maybe isn't, the details someone might want to hear, but I'm going to say we have to find the time. We have to find the dedication. We have to find the wherewithal to educate for these critically important pieces that are going to be continuously added to our EMS plate. It's a really tough, and I know Chris Reither well, who asked this question, and Chris is a EMS educator extraordinaire. And I feel your pain, my friend. We all do. We've just got to encourage folks that if we don't have the time to educate them, that they have to find ways to glean this education, under the auspices of their employ. So, whether in the fire station or the EMS space, we've got to have in-house education training. We've got to have better online accessibility. But big question, lots of answers to come, and it's an area we absolutely need to address overall. Thank you for that.
Great, thank you. Yes, I couldn't agree more. And education is such an incredibly critical component. And as we heard from our last speakers as well, that feedback loop between the hospital and the providers can really help enhance systems. So that's a component that we can continue to work on to improve that real-time data sharing that can support providers' clinical judgment and reinforce what they're seeing out there in the field. So thank you for that.
That's so important. Your point is huge, Nicole, and it kind of reaches into another deep pocket, which, the whole HIE and immediate feedback, immediate sort of reward loop that EMS loves so much. If we can get our EMS providers this immediate feedback, we will, create enthusiasm for that learning piece and, make them want to reach out and find the answers, in their own buckets. But until we can do that, people lose enthusiasm if they don't figure out what happened to that patient or if my intervention made a difference. So great point.
So I'm seeing a few questions just about resources and access to understanding what makes up stroke systems currently, or what hospital designations are, who are the point people in their system. Are there any resources, and I open this to the whole group, resources where hospitals or EMS systems, individuals can get information on not only their system, but systems across the state in terms of which hospitals are designated, what level, and who the primary contact people are at those systems? It seems like being able to share knowledge and communicate across systems would be really valuable, especially for systems that maybe are just starting to really develop their stroke plans.
Probably I can address the question. Since we started developing a survey, as Dr. Bassan also, she knows, she's part of creating the survey, and we're going to spread out this survey to all the LEMSAs and regarding all the information for this stroke systems. And then after gathering all this information, we put it together, we organize it, and we're going to post it in our website and spread it publicly.
Thanks, Fareed. And a follow-up on that, is there any information about, in that survey, about technology in terms of what systems, I mean like technologic systems in this case, that LEMSAs are using, say, to facilitate communication between hospitals and EMS, or is that not part of the survey?
No, we didn't put any technological, system, but it's mostly about, the level of care, the hospital, the stroke centers level of care, and also the collaboration between LEMSAs and counties for sharing the patient with each other. Also with if they are collecting data and they're sharing data with the state at the state level.
Okay, great. So perhaps after that survey data is out, we'll have some contact info for each system, and that's a way that people can reach out about specific questions in terms of learning more about what different systems are doing.
Absolutely.
Are you requiring all LEMSAs to have stroke plans by a certain date? It seems like not all LEMSAs yet have stroke plans submitted.
As you guys know, the stroke regulations is not mandatory. It's basically voluntarily, but each LEMSA who decided to adopt this system, they have to have the plan for submission to the EMSA and approval. But if they decide not to be part of this system, that's their decision. So by law, we are not basically forcing anybody to join this system, but we are encouraging and we are hoping all the LEMSAs around the California statewide, they join this system, they be part of this great system, and then we're going to have a standardized, care all over the California.
Excellent. I'd like to shift to data for a second. I
Okay.
know everyone loves data. Data is everyone's favorite topic. But Tom is here with us, and there are some data questions. First, are the data elements required by EMSA regulation for stroke met by hospitals that use, excuse me, I'm not doing a good job on this question. Let me try again. Are the data elements required by EMSA regulations for stroke met by hospitals that use common registries? So say a hospital is participating in a common registry, will they automatically meet the requirements for EMSA's data regulations?
Hi all. No is the short answer. Just because somebody is in a particular registry doesn't mean it necessarily reflects the elements that we asked for in the regulations. I do know that some of the registries that have been developed did take the regulations and use them as part of their modeling, but I don't think that's universal across the ones that I'm aware of. So there could be some variation where somebody would have to pick up an odd element or two that may not be part of the registry they have in operation.
I see. So they really need to look at the regulations and see where the gaps might be in terms of what they're submitting currently through perhaps their Get With The Guidelines Stroke or other databases.
Yes, exactly.
Okay. And in terms of EMSA's data reports, in a lot of the LEMSAs, the local EMS agencies may have one-off reports or additional data that they collect. Are any of those included in the EMSA reporting if LEMSAs collect, say, additional data or interested in other metrics?
So is it collected? Potentially the answer is yes, depending on the way the file is sent to EMSA. If the information is sent to us as a batch, just i.e. everything stroke, then yes, it may be in our system. But if it's there, that doesn't necessarily mean we can query it or do anything with it. It has to be visible to us and then machine understandable for the system that we're using. And where a LEMSA or a hospital may collect an odd widget, if you will, if our system isn't set up to take that widget and do something with it, then we're not able to report on it or otherwise and see there is something there. It makes it very difficult for us. And there are some variations to this that give us opportunity, and we are looking at those, but unfortunately, it's not something that we can do right now.
I see. This question just popped up. It's directly related. So is there a specific list of EMSA data requirements?
There are, and they're exactly those items listed in the regulation.
Perfect. So if they look at the regulations, they'll have the list of data elements that they need, right?
Yes, they will.
All right. I was hoping, and Dave can weigh in on this too, not just about, the specific data elements or how to submit them, but can you provide a little bit of EMSA's vision in terms of kind of the long-term goal for data flow, reporting, and sharing to promote this concept of measure and improve?
Yeah, I'll try and give that a brief shot. It's funny that question gets asked right now because we're literally in the middle of sort of revising what is our vision for statewide data reporting, EMS integration, and what we're calling just bridging of all the data silos that we have access to in the state. And so, I mean, if I could put this into one word or one line, the answer would be all the data in real time. So that's the end all be all zebra that we could dream about. All the data, all the time, real time. How do we get there? We're a long way from there. So we do this with single steps, probably moving through 100 of them. But the way we get there is by continuing on many of the paths we're already on. Some of the biggest you've already mentioned, health information exchange build out, so that we can link EMS with hospital records. I think that's one of the first and foremost keys for us all to have better access to something that resembles more real-time data access. We are currently in the process of doubling the number of sort of HIE accessible, sorry, it's going to be redundant, HIOs within the state. So we're going from somewhere around 15 to 30 of those over the next year, we're hoping. So we'll see a lot better data integration. We've brought on, and Tom McGinnis gets the lion's share of the credit for this, we brought on a machine learning analytics company. They're more of an agency than a company, called Biospatial, that's going to let us visualize, analyze, have better access to dashboard-like data for all of our EMS systems. And that's not just an EMSA access point. We built in that all the LEMSAs will have direct access to these biospatial tools. So we're working on building that out in short order. The real challenge is linking all the data sets and making those linkages displayable in some real-time or near real-time fashion in the form of dashboards. So that, I mean, if we can think about, instead of maybe 100 different registries, if we could think about dashboards that allowed ready access to all the registry data and analytics associated and available to utilize with that data, that would sort of be the end all be all that would get us the immediate answers we need with respect to outcomes and interventions that, right now are so difficult to pull off, because either we're not getting the data or the data is taking a quarter to get back to us. So that really doesn't allow rewards for any of us in its current form. I hope I wasn't too ADD-ish with that one.
No, that's great. I think, it's all about that real-time data. And the question is, how quickly can we get there? And it's challenging. There's a comment, I think even more than a question, from Joe in the Q&A, really discussing how it would be optimal to have real-time QI training for our providers with immediate feedback and reporting on outcomes to them to help support this, and dashboards that can immediately show systems how they're doing can also be that kind of system equivalent in terms of getting the data immediately to people that can then take action to improve on it.
I just couldn't agree more. I could not agree more with that statement. I lived in that space for a long time. I mean, a couple of decades in the air ambulance world and then in the CAL FIRE world. And I so feel your pain. That data is not available. We don't know if our QI is, working, if the interventions we're doing have made a difference. There's so many pieces we need immediate answers to be able to deliver, the best care available. Tough area.
Well, I think that's, it is. And I think that's a great place to end, since we're coming to the end of our time. And I'm going to turn it over to Fareed to close us out with a few ending comments. But thank you all so much for making this time and for supporting this summit.
Thank you, Nicole, and all. Really appreciate your participation and pulling this thing off in such a high quality fashion.
Absolutely. Thank you, Nicole. And before everyone go, I would like to thank you all for joining us again. I hope you all are agreeing with me about the fantastic presentations. I have a special thank to all the presenters for the great materials. Also for the summit committee members with the leadership of Dr. Nicole Bassan for all the hard work you have done to conduct this summit. I also would like to appreciate American Heart Association and Kaiser Permanente for their collaborations and support. The recorded summit will post in EMSA website for the educational purposes if anybody were interested. Within a week, please look for an email in your mailbox regarding how to claim your CE and CME with completing your evaluations as well. I apologize for any technical issues you might have experienced. I hope you enjoyed this summit and hopefully seeing you all in the next summit face-to-face, not just virtual. If Dr. Duncan doesn't have any comment, I would say goodbye and have a great rest of the day.
Thank you, Fareed. Thank you all. Appreciate it.